Lalit. He is going to chair the session. So with Dr. Lalit, I'm the co-chairperson. We have Dr. Ajay Kapoor. Dr. Bajwa is here. He is not there. Then Dr. Neha has come. So this is a session on basics of medical retina. We would like to make it as interactive as possible. The time constraint is certainly there, but we will try to have questions, 2 questions asked after each session. So can we have the first speaker, beyond simple inhibition, the multifaceted molecular characteristics of anti-VEGF agent? Veer Singh is there? Dr. Veer?
Veer Singh is there, I think. No?
No, I don't see him.
Achha. Neha? Guliani? So you are going to talk about Octa. So Neha, my only request is tell practical points. Don't go into theory of OCT, Octa, whatever. Sirf practically kahan aap use karte ho. That's all. Only pictures where we can get benefit out of it. Okay. As Ajay was saying, aim is to have some interaction rather than theory. Google to bahut hai. No, Ajay?
Yes, sir.
So good evening, everyone. So I'll be presenting my talk on role of Octa in retina practice. And at the outset, I would like to thank AIOS for this opportunity. So what is OCTA or OCT angiography? Basically, it's a non-invasive imaging technique which is used to provide a 3-dimensional visualization of the retinal and choroidal vasculature. So basically, how is it different from OCT, or how is it an add-on to OCT? So OCT, basically there's a light beam which is split into a exploratory arm and a reference arm. And the difference between what the signals we get between the two is made into an A scan. So what Octa works on is something called as motion contrast. So retina per se is a static tissue, but what is moving is the red blood cells in the retinal vessels. So what happens is that if we take multiple A scans at a single point, the static things will not change, but what will become apparent is the things that are moving, the red blood cells. So a decorrelation signal is made, and this leads to a decorrelation map, which we see as an Octa map. So as we all know, there are different OCT technologies: time domain, spectral domain, and swept source. Swept source is the latest. It has a longer wavelength, so more penetration, better choroidal view. But the thing is that it is costly. So why Octa? Till now, our mainstay of retinal vascular imaging has been fundus fluorescent angiography and ICGA. So what Octa is, it is non-invasive. It is not using any dye. So the risk posed to the patient because of the use of dye, which can be from a mild allergic reaction to anaphylaxis, we do not encounter that with Octa. And plus, because there is no dye leakage. So there is no obscuration of the retinal structures because of that. Also, it not only images the superficial capillary plexus, but the deeper capillary plexus are also imaged. And a better visualization of choroid is there. So we've discussed all these points, and it is useful in patients who have a contraindication to that dye, patients with chronic kidney disease or any other relative or absolute contraindication to the dye. And because it is non-invasive, we can do it again and again. We can do it in cases which require recurrent vascular images, which are such as patients which are being treated with anti-VEGF therapy for AMD or DME. Where there are so many advantages, there are limitations as well. So because you have to take multiple A scans at a point, so the imaging time increases. The field of view is restricted, so the peripheral retina cannot be imaged that well. And it cannot, as I already told you, visualize dye leakage, so which is a common landmark of vascular inflammatory pathology. And it is riddled with artifacts. There can be a motion artifact if the patient moves the eye or patient blinks, so you'll have those lines. Or there can be a projection artifact where the superficial vessels, they are projected onto the deeper layers. There can be a segmentation artifact where there is edema, so we have those segmentation lines. There is an upper and lower border, and these segmentation lines lead to the formation of those slabs. So then we might misinterpret the results. So moving on, how to interpret an Octa scan. As a general rule, we have to keep in mind that we have to look at these few things together. First is the NFAS image. Then we have to correlate it with the B scan, with the flow overlay, and also the intensity, the structural intensity image. So for example, this is the fundus photograph of a known case of AMD. So our area of interest is the macula, and the OCT has been done through that. So these are the various slabs that we see in OCTA. This is the full retinal thickness, this is the avascular slab, and this is the choriocapillaris. So as we see in the choriocapillaris, you can see this well-defined network of vessels. Now we'll correlate with this with the B scan and the flow overlay. So you see that in the B scan also there is this irregular PEDs, and you see those, and you see the flow below the RP. This suggests that this might be type 1 MNV. And also the signal intensity is good. So there is not much of shadowing artifact. Now, where do we clinically use Octa? So it can be used in diabetic retinopathy, retinal vein occlusions, and AMD. Now, how is it used? So Octa, because it is non-invasive, so it can be used for screening as well as follow-up in the patients. So in diabetics, we can see an enlargement of the FAZ or their vascular changes. Like here, you can see that NVD can be very well appreciated on Octa as meandering vessels, and there is hyperreflectivity at the vitreoretinal interface. That's another picture of neovascularization at the disc. Similarly, here there is reovascularization at disc. This is before laser and this is post laser, so you can see the regression of these newer vessels. In retinal vein occlusion, what Octa shows are areas of vascular non-perfusion and microvascular abnormalities and neovascularization. So here you see this area, this dark area. This is the area of capillary dropout, and these are the new vessels. This is the neovascularization elsewhere. For in AMD, the role of Octa has been invaluable because it can image the deeper layers better. So the ability of Octa to visualize the choriocapillaries in intermediate AMD and later stages of disease has shed light onto the etiology of this disease. And based on OCTA, basically we classify, as you all know.
Would you say etiology or location only? No?
So location, basically the location, whether it is type 1, type 2, type 3, depending on whether it's sub-RPE between the retina and the RPE, or it is coming from above and then...
Neha, you can wrap up soon.
Hanji, sir. So this is a picture of, this is an OCT of a CNVM with subretinal fluid, and on Octa here you can see a neovascular membrane at the RPE fit. Similarly, this was a case of polypoidal choroidal vasculopathy that came to our OPD. So on the B scan, you can see flat irregular PED, and on Octa, you see this branching vascular network. And this is a follow-up of the same patient after multiple anti-VEGF injections. And you can see the reduction in the intensity and the branching of the vascular network. So what I want to say is that Octa, is being a non-invasive technique, can be used in cases where the dye is a relative contraindication, especially in cases of AMD where the imaging of the deeper layers is much better with OCTA. Thank you.
Thank you, Neha, for enlightening us on Octa. We will have some discussion after all the Octa talks finish. Next is Dr. Sachi. She will tell us about progression of NPDR in Octa. You see, what we would be interested is to show your cases where you have become wiser. You see, Octa, I think everybody will know what is Octa, at least the retina crowd will know what is Octa and what is the theory behind it. Where in patients of NPDR you have become wiser in by using Octa. So I'm going to question the same thing to Neha, and we'll have some panel and audience question. कहाँ पे Octa ने तुम्हें फायदा कर दिया? You see, we all know it's a dye-less angiography, it's a series, that's okay. But you tell us, you know, in the progression of NPDR, कहाँ पे फायदा हुआ? Yeah, बताओ. Yeah, presentation. Yeah, sure. What I'm saying, just lay emphasis because I think all of us want to hear that.
Good evening. I'm Dr. Shachi Srivastav. I'm from ASI Medical College, Faridabad, and I'm thankful to AIS for giving me this opportunity to speak on this topic. My topic is role of OCT angiography in monitoring the progression of non-proliferative diabetic retinopathy. Currently, we're also doing a thesis on this topic, and we have discovered some things which we'd like to share. So first, we'll go on a general discussion. I think we have already know that diabetic retinopathy is currently the leading cause of vision
Let's
loss.
Sachi skip this. ये OCT ये एंजियो डायबिटीज़ क्या है उसको छोड़ देते हैं. Let's come to ऑक्टा सीधा. यहाँ FA and ICG.
So basically, ma'am has already told you the principle of
Yeah, yeah.
OCTA, how it is relevant in cases of diabetic retinopathy that we need to know. We need to know the importance of the superficial and deep capillary plexus and the algorithm which is used to detect the motion of erythrocytes in the capillaries, which helps us in estimating these plexuses. So basically, OCTA detects the vascular changes at the level of 3 capillary plexus: superficial, which is within the ganglion cell layer; intermediate, between the inner plexiform and inner nuclear layers; and deep, which is between the inner nuclear and the outer plexiform layers. So it can automatically quantify the size of areas with and without perfusion, that is the flow and non-flow areas, and FAZ and the capillary density, which is VD. So VD actually represents the proportion of the surface area of blood vessels relative to the total measured area based on binary images to determine the perfusion of retinal microvasculature, which is very important in cases of diabetes. So previous studies have shown that OCTA is able to delineate retinal capillary non-perfusion with higher resolution than the conventional FA. In early detection, it can detect changes at the earliest stages of NPDR, even before the visual symptoms or signs appear on standard fundus examination. It offers detailed images of retinal capillary network and allows the visualization of microaneurysms, dilated capillaries, dropouts, and the tortuous vessels, which give an idea of the disease progression. It provides quantitative metrics such as vessel density, FAZ. They act as objective indicators of disease severity and progression. It can effectively measure the area of retinal hyperperfusion or ischemia, a critical factor in the development and progression of NPDR. It helps in predicting the risk. Quantitative findings can help in predicting the risk of NPDR worsening or development of complications like diabetic macular edema. Its applications also include measuring ischemia, detecting neovascularization at the earliest, and timely treatment. So into OCTA's ability to segment the various layers of retina, it can easily detect the neovascularization from the earmas, which may not be always possible on FA or clinical examination. So this is one advantage. It also helps in differentiating NPDR from PDR and helps us in following. Various quantitative measures which have been described are the area filled by binarized vessels, vessel density, vessel spacing or the intercapillary area, length of the blood vessels based on the skeletonized OCTA, which is the vascular length density, vascular diameter index, total length of the vessels, vascular architecture and branching, and area of the FAZ. So these are basic quantitative factors which are important in determining the progression. So vessel density, as I've already said, is the proportion of blood vessel area over the total measured area. It decreases both in deep capillary plexus and superficial capillary plexus of a patient with DR, as well as diabetic patient without DR, attributing to fact that parafoveal capillary non-perfusion in DCP may potentially be an early sign of DR. Vessel density in DCP may predict DR severity and identify patients at risk, as it is able to detect retinal vascular changes in diabetic patients without any signs of DR. So this is very important. We can detect NPDR even when there are no clinical signs. Intercapillary spacing can be detected by areas that are not perfused, and they occur much earlier than the VD changes. And the extrafoveal avascular area may help to distinguish early NPDR from the healthy eyes. As capillary non-perfusion area enlarges with progression in severity of NPDR, the quantitative analysis of retinal non-perfusion on OCTA may be useful for early detection and monitoring of disease in patients with diabetes and NPDR. Vessel tortuosity is also a quantitative factor from fundus images via computer-assisted software. It is an integral of the curvature square along the path of the vessel. Basically, this is a parameter, and patients with diabetes, they have increased vessel tortuosity as compared to healthy controls, and they're related to mild and moderate stages of DR, suggesting that vascular tortuosity may be an early indicator of microvascular damage in the retina. So these are very important parameters which help us detect NPDR and also help in detecting the progression of the NPR, because these parameters increase with the severity of NPDR. It may also be used to distinguish moderate to severe NPDR from PDR, particularly in the superficial capillary plexus region. FAZ area and acircularity correlate with the vascular tortuosity in this zone of superficial capillary plexus. As this parameter increases with worsening of NPDR and it decreases in PDR, it may serve as a quantitative marker to monitor the progression of diabetic retinopathy. Diabetic macular ischemia is characterized by occlusion and loss of macular capillary network or capillary dropout, and non-perfused areas in DCP and reduced VD. They reflect the macular photoreceptor disruption in diabetic macular ischemia. So we can all detect diabetic macular ischemia at the earliest also by OCTA. In the area of disrupted ellipsoid zone of photoreceptor, choroidal circulation layer had a greater area of flow void, and hence alteration of choroidal circulation appears to also play a role in the pathogenesis of NPDR and DMI. Wide field OCTA images have shown that large arterioles situated in superficial and deep layers seem to be the perfusion boundaries, which may serve as a novel anatomic factor to predict the likelihood of non-perfusion development. To summarize, OCTA plays a growing and significant role in monitoring the progression of NPDR by providing detailed, non-invasive imaging of the retinal microvasculature, helps in early detection of the microvascular changes, helps in identifying the subclinical signs of progression before they are visible ophthalmoscopically. They help in monitoring the disease progression. Repeated OCTA scans, they allow tracking of FAZ enlargement, decreased vessel density in the superficial and deep capillary plexus, and worsening the capillary non-perfusion. These parameters, they correlate with NPDR severity and risk of progression to proliferative diabetic retinopathy. It helps in evaluation of macular ischemia, which is very important in predicting the visual prognosis of a patient. It differentiates ischemic from non-ischemic diabetic maculopathy and guides the treatment decisions. And it is a non-invasive and a repeatable test. So this is FAZ in a healthy eye. And this is FAZ in NPDR, which is evident by enlargement. And this is the capillary density in the superficial capillary plexus. I'm just showing you the images. So there was some problem in the machine, in our OCT machine, so I couldn't get the original images, so I'm just... So basically, this is just a representation through images how the FAZ, the superficial capillary plexus, is affected in patients with diabetic retinopathy, and it gradually progresses. What are the limitations which we cannot forget? It cannot detect vascular leakage, which is a key marker of disease activity and is clearly visualized with FFA.
Sachi, I think limitation she has covered quite a bit.
Thank you.
So we'll have a brief discussion on OCTA, you can please. So we'll start with some panel and maybe some audience also can react.
Anybody from the audience has a question or you have any doubts which you would like to clarify about OCTA?
I'll just begin this by saying, do you today do OCTA in all NPDR patients? I for one do not do it, isliye I am saying, because I do not take any patient to that OCTA machine if it is NPDR just for the sake of picking early or just to predicting risk, like you are saying, progression. But I know OCTA is an upcoming tool, and it all depends on how much time you have. Exactly. You see, if you have few patients or research element, then I think it does help to quantify all those void areas and these areas. But from practical clinician point of view, in NPDR for study, DCP layer is the most beneficial in diabetic retinopathy. Yes, sir. But in NPDR, Ajay, do you take all patients to OCTA?
So if we have evidence of any evidence which suggests you have diabetic macular edema, we do an OCT. Yeah. So that's a must that any patient...
No, we are talking of only NPDR. Yeah. We are not talking of maculopathy
so
at all.
NPDR with a diabetic macular edema, I'll do an OCT. NPDR without diabetic macular edema, I will, if I can explain drop in vision, I will I will definitely not do an OCT, but if it is required as a standard, most patients we do an OCT. And in case we find that we cannot explain the drop in vision, we do also do an Octa in these
Ajay,
cases.
Kapoor,
Sir, actually with Okta, you really need to spend time with the
Yeah,
machine.
yeah,
You need to talk to the machine. And again, in a very busy clinical OPD, like you
Neha,
have 50,
no, but
70
I wanted
patients.
this answer only. Yeah.
So
Very
for
difficult.
NPDR, we do not
Yeah.
routinely do Octa.
So what patients, both you, Neha and Sachi, you take the patient to Octa as a routine?
So currently, as I told you, we are doing a research on this topic.
Yeah,
so
yeah.
obviously, we are doing Octa. But I think it's very beneficial in cases of severe NPDR because it can identify any subtle NVE, and also in those patients who have diabetic nephropathy, where we cannot do FFA. I think it's always better to go for an Octa.
Okay, that point I would agree that
in
in
nephropathy,
such
definitely
patients,
it has a.
Where there is
you know,
contraindication.
Ajay Arora, two Ajay, so I have to say, Ajay Arora did point out that wherever you can't explain the vision loss, then it's worthwhile taking, that will take few seconds only, ischemia is there or not. That will definitely tell.
And other situations is if you've done an angiography in a case of, so a patient walks in first to my clinic and there's significant amount of non-proliferative diabetic retinopathy, and this patient we would probably subject him to a wide field angiography. In case I find a vessel of IRMA, then OCT angiography differentiates between IRMA and neovascularization very well.
Correct.
And
Yes,
that
sir.
point I think you must point out, because I was going to hear that point that is very classical, that how do you differentiate an NVE from an IRMA and an Octa? I think that is one important point which should go back to the audience, and that is where segmentation comes in. So if you, would you like to point that out or want me to speak
So I
on?
would like you to explain.
You can explain.
So basically when you look at IRMA, any NVE will breach the ILM, while an IRMA will not breach the ILM.
Because
So
that's a
therefore, if I do an
intraretinal.
Octa at the level of the ILM and I move my cursor and I move the whole thing above, then I can see where the breach is occurring. Remember, one movement of the cursor is 10 microns. One single movement of the cursor is 10 microns. So if I move the cursor twice, I have moved 20 microns. So by that I can gauge how much above or below I have moved every time. Sometimes the segmentation is not done by the machine correctly, so you have to manually segment. And this is more common in AMD patients, where you have to, segment and get the levels right,
In
and
fact,
then you
most
can
of time we
sequentially
end up
follow.
doing manually only. That's the best way to study. So I think thanks both to Neha and Sachi for having some discussion on Octa. But believe me, it's an expensive tool. Gradually, a lot of us are depending on Octa, but it still has not replaced FA. FA is not dead. FA still people are doing, but Octa is giving a lot of information because of this RBC movement and all. I think, Ajay, we should move on to the next, because I'll be very excited to listen to Rhythm Nanda when she says setting her practice, will he say Octa lena hai or OCT lena hai? So we'll listen to him also. In between, let's have Abhishek to tell us about ERG, EOG for general ophthalmologist.
Thank you, AIOC2, for giving me this opportunity. My topic is ERG and EOG for general ophthalmologists. So with this certain case presentation, I would like to simplify this topic for our general ophthalmologists. So ERG, it is just whenever light is exposed over the retina responds it by producing certain action potentials, and ERG catches those action potentials and display it in form of wave or in a form of graph. So this is a very simplified version. So, and the photoreceptors are mainly rods and cones. So rod photoreceptors, they are best activated in dark adapted state. So we get these three waves for rods. And if we have to study the cones, then they are best stimulated in light adapted conditions. So we get these two waves for rods, for cones. So any disease which is hampering the rods, the upper three waveforms will be diminished, while any disease which is hampering the cones, the lower two waveforms will be diminished. So I will show with certain case presentations. some case scenario. So whenever we interpret an ERG, so first we should pay minute details to the complaints of the patient, correlate with the clinical signs, the vision, the anterior segment, posterior segment findings, and then finally we do an ERG, and finally we correlate everything to come to a diagnosis. So like this case, a 14-year-old boy presenting with complaints of progressive loss of central vision and diminished color vision. The vision is 636 and 624, and since childhood it is progressing. So here it is poor color vision and photophobia. So this shows that the cones, so here from history only the poor color discrimination shows that the cones are affected. So this is the fundus photograph showing a typical bullseye maculopathy. The field is normal. So we do a ERG. So this is a normal ERG. Now you see this. These are the two rods waveforms and these are the cones waveforms. So here you see the cone waveform should be like this, but this is markedly diminished. But the rod waveform is more or less intact. So now this tells us that this is a predominantly a cone dystrophy, a disease of cone dystrophy. And if we follow that child for a certain few years, for 25 years, then secondarily the rod also get affected. Now see this waveform. So here you compare this waveforms. So here the rods have also diminished. So this boy presented with a cone dystrophy, which finally, with a progress in age, converted into a combined cone rod dystrophy. Now coming to another child. So this is a 3-year-old child and presenting with severe loss of vision with wandering nystagmus and unable to pick up objects. So this shows that child has loss of vision right from the birth, and there is severe loss of vision with wandering nystagmus. And this child is showing the classical oculodigital reflex. The fundus, both eye, is more or less normal. So now if we do an ERG, so this is a normal ERG, how a normal ERG should look. Good A wave, B wave, all the waves should be normal. But now see this. All waves are, both right and left, they are flat lines. So this ERG is in contrast to the previous case. Here all the waveforms at 3 years of age only is totally flat. So neither the rods nor the cones have developed. So this is a case of Leber's congenital amaurosis, which is characterized by early onset, rapid progression, severe visual loss, and wandering nystagmus. Vision can range from 660 to PL plus minus. So now coming to another case, this is a 24-year-old male presenting with 624 vision both eye, and now he is complaining of loss of color vision and night blindness, both. And this symptoms has persisted right from childhood. So this is the fundus picture, more or less normal, OCT within normal limits. Now we do the ERG. Now see this. So you see here, this is how this waveform shows a normal, how a normal wave should look. So here you see the dark adapted rod waveform, it is slightly diminished. And similarly the cone waveform. This should be a normal waveform, but now this is the black line which shows it is the very flat line. So this patient is presenting with a mixed form of cone rod dystrophy. And why we tell this as cone rod, you see, the cone waveforms are totally flat. But here the rod waveforms, they have certain potentials. So this is a predominantly cone dystrophy, which is secondarily impacting the rod photoreceptors also. This is a cone rod dystrophy. In rod cone dystrophy, this will be opposite. It will be exactly opposite. Okay. So coming to another case, a 14-year-old, now just see the presenting complaints. 14-year-old girl presenting with only diminution of vision during night time. She has night vision difficulty. And this, she is telling this that she is right from childhood, she has this problem, but vision is 6/6. Anterior segment is not. Vision is 6/6, but only night vision problem. This is the fundus, which is looking very much normal. So this is in dark adaptation where a fundus photo was taken. After light adaptation, again fundus photo is taken, and this is showing a peculiar yellow iridescent color, which is actually the mesio phenomena, which is classically seen in congenital stationary night blindness. And how do we confirm it? We do an ERG. This is how a normal waveform should look. This is the rod waveform, and from complaints only we know that we have to look at the rod waveforms because she is complaining of night vision problems. So this is how a normal rod waveform should look. A good A wave and a good B wave. B wave is always greater than the A wave. But when we do this, now see this, A wave is good, but this B wave has not reached the baseline, but rather it is below the baseline. So this is a classical case of electronegative ERG where B wave is negative. So this is which is classically seen in congenital stationary night blindness. So this patients generally they complain of night vision abnormality, and it is generally static with either fundus appearance or without fundus any problems. Coming to another case of electronegative ERG, a 12-year-old boy presenting with diminution of vision, 624, 636, anterior segment normal. On fundus photography, you can see there are certain macular changes, certain cartwheel appearance, which is confirmed on OCT, where there is intraretinal schisis, schitic cavities. So again, if you do an ERG, this is how a normal waveform should look, a good A wave, a good B wave. Now when we do this, now see this, A wave has formed, but B wave is not reaching the baseline. So again, a case of electronegative B wave or electronegative ERG, which is classically seen in juvenile X-linked retinoschisis. So this case is seen because in most of the cases, we don't get to see this classical or where the sciatic cavities are very less. So there we might miss the diagnosis and we can term it as occult macular dystrophy or something like that. But after doing, if you get an ERG like this, electronegative ERG, then you can confirmly say that it is a case of juvenile X-linked retinoschisis. Okay. Now certain acquired condition, a 50-year-old male presenting with diminution of night vision. Again, night blindness, alcoholic liver disease. So alcoholic liver disease, night vision. Sir, shall I continue? Yes. So a 50-year-old male presenting with night vision problem. Again, we know that there certain rods are only hampering. And to add up alcoholic liver disease, so liver metabolism, rods, photoreceptors are involved in liver metabolism. Okay. So again, vision, fundus photo totally normal, OCT normal. But if we do the liver function test, vitamin A is severely deficient. So this patient had vitamin A deficiency, which was impacting the rod photoreceptors. So at presentation, now you see, so you see the black line, which is the rod waveforms, they are totally flat. Compared it with the cones. Cones still have certain waveforms. So cones are healthy, only rods have diminished. So what is the problem? Just give vitamin A. So after treatment, you see now the waveforms of A and the rod waveforms have totally picked up. So this is how ERG helps in certain conditions. One case I would like to show you.
Last
case. 63-year-old male presenting with rapid onset diminution of vision, and he is complaining of not actually diminution of vision, it is actually shimmering photopsia and night vision problems. 63-year-old male, anterior segment normal. So just we go back to the previous history, he had history of cutaneous malignant melanoma in his left forefoot, which was surgically excised, the margin was clear. Sentinel lymph node biopsy was advised, but he denied for it. So at that time, 2 years back, the metastatic workup was done, which was totally normal. No metastatic disease was present. But after 2 years, he is presenting with photopsia and diminution of night vision. So again, fundus photo, normal, OCT, normal, FFA, normal. Fields is showing gross suppression of fields. But what is the cause, we do not know. We do a ERG, again you see, B wave should have A wave, good A wave, B wave should have come to the baseline and should have gone above. But it is stopping behind the base, below the base. So this is again electronegative ERG. So electronegative ERG we have seen in congenital night blindness, congenital stationary night blindness, juvenile X-linked retinoschisis. This is a case of, and certain autoimmune retinopathy we can see. So this was a case of melanoma associated retinopathy, which is actually, so in this case, a full body PET scan and CT scan was done, and which showed local recurrence of that. So previous history, the 2 years back, that malignant melanoma has recurred, and it has metastasized all over the body, and which was producing autoretinal antibodies, which was going and attacking the rods and cones. So this is a case of melanoma-associated retinopathy, again, which is characterized by electronegative ERG. So sir, I shall stop here.
Yeah, I think we should stop in interest of time, but I was very excited to see the last patient which you said, because everything was normal, except fields, but haven't seen such, practically haven't seen. All the rest 5 scenarios were reasonably,
yes,
familiar and
yes,
which we have seen. But this last case where everything is normal, I was just...
one more case I have of carcinoma. One was melanoma, so MAR and CAR. CAR is also there. If
yeah, you can show, in fact,
10 seconds,
more
10 seconds is there.
it.
So if you can.
So in the
You see
case of melanoma, your disc was normal.
Everything was normal.
Yes, sir. Color fundus photograph is there.
Okay.
So if you can.
So you see, what I was wanting to know was ERG, EOG should not be a dustbin kind of, diagnostic tool that ye samajh nahi aa raha, samajh nahi aa raha, ERG, EOG kara lo. That's what most people do. We wanted that, you have illustrated where it has made a difference, like chronic liver disease, vitamin A deficiency, like ye CAR and MAR. They are a couple of scenarios where you definitely become wiser. In a patient of RP, retinitis pigmentosa, even in cone dystrophy, it's okay. Leber's also you can suspect. You know that both rod cones will be gone. But in CAR, MAR and the chronic liver disease, I think they were very, very informative. No, Ajay?
Yes, sir.
Both the Ajay.
And in cases of X-linked retinoschisis, I think once you got the diagnosis on an
Schisis
OCT,
also, yeah.
Schisis, you may not subject them to
Yes,
electrophysiology.
it is only when there is subtle, when schisis is very subtle in the early stage.
No,
So-
वो अभिषेक OCT में दिख जाता है.
हाँ,
Because I don't think so ERG is required for that kind of diagnosis. You see, showing electronegative ERG in Schisis, which is visible on OCT, what great thing, nothing. But in CAR, MAR and chronic liver disease, I 100% agree. So any other comment by anybody else? So thanks Abhishek for wonderful,
I think the take home should be that don't be afraid of looking at electrophysiology. Most of us don't want, are scared of electrophysiology because we have not seen it during our practice or not seen it during our post-graduation. But I think all of us should learn the basics of it. It's important.
Very nice. So let's hear now Rajvinder about end of pearls.
Yes, sir. Good afternoon, everyone. The topic is acute postoperative endophthalmitis. So the dream of every surgeon, the ideal post-op. Round central pupil lens in the bag with the vision, post-op vision 6/6, good glow, and wants to see happy patient. But we all see the patients of endophthalmitis.
Rajvinder, थोड़े practical example
Practical
दिखाओ, हाँ,
example
because
Okay, sir. So the incidence of post-cataract surgery is 0.26, which is higher in the clear corneal incision, keratoplasty 0.3, and bleb associated is
0.26 ज़्यादा नहीं है, 0.26 तो बहुत ज़्यादा
0.26.
incidence है.
Higher with clear corneal, sir.
हाँ,
ज़्यादा
नहीं
है?
even 0.26 तो बहुत ज़्यादा incidence है. आजकल तो 0.01 की बात हो रही है.
हाँ जी, sir,
Nobody accepts
0.01.
0.2.
Okay.
0.2 कहीं कहेंगे तो मार देंगे लोग. 0.26 too high, no?
So the
Yeah, nowadays after all those preventive steps, 0.01,
Okay.
0.1 भी बहुत ज़्यादा, 0.1 in 1000 नहीं होता.
0.01.
Yeah.
ठीक. So prevention is better than cure.
Yeah.
So identify the high risk patients, especially the diabetics. You can always glycosylated hemoglobin in these patients and urine routine and microscopic and complete blood count.
ये urine test करना बंद करना चाहिए. Honestly, I'm telling you. You see, I have a strict mismatch of this thing. Urine test करने से कुछ नहीं है, बता रहा हूँ. Lot of people हो hemogram, urine, CBC, कोई relevance नहीं.
So
Don't have that bunch of investigation. वो patient ले आते हैं, डॉक्टर साहब ये देखो checkup. वो तुम देखते रहो.
sometimes they have UTI, and in those cases
वो
they
तो
can
clear
have.
cut है. That's clear cut.
Yes, sir.
That history will tell you.
Yes, sir.
चलो आगे.
So in males, it is essential to rule out prostate-associated inflammation also.
कोई देखा तुमने prostate inflammation से किसी को end up हो गई हो?
So I had
दिखाओगे
one
अच्छा.
patient. हाँ जी. Always check Croplas and always assess the lid margin for blepharitis and meibomian gland disease, and always assess the dry eye. So preoperatively, when we are doing CAM surgeries, we can always use preoperative topical antibiotics. When we are admitting the patients in the ward, we can instill the drops as well as eye ointment at night. So soap washing of a face, feet and head bath should be advised to the patient before surgery, because we know the CAM patients are poor patients, they are from rural areas, so better to take all these precautions. Double draping, one outside the OT, that is Betarian wash in the ward, or second in outside the OT, and inside the OT can be done. A day before the surgery, if there are patients in the ward, and you can still the eye ointment.
The only thing which has level 1 evidence is betadine and face wash.
Yes, sir.
Nothing more.
Rest everything is for your satisfaction.
Yeah,
You see, putting ointment at night and putting antibiotic drops 3 days before. No
So
level 1
in the
evidence.
OT for 3 minutes, the betadine
Betadine is okay.
for 3 minutes.
So let's come to practical.
So the practical pulse for perioperative, that is the double betadine wash, 10% betadine on the skin, and keep eyelashes away from the surgical feed. So it is very important to proper draping of the eye. 5% in the conjunctival sac for 3 minutes. So if the surgeon feel like he is not having time inside, we can instill the eye drops outside the pre-op room. So intraoperative precautions, that is the sterile instrumentations, good quality fluids, tight hydration of the ports, proper wound construction, suture whenever you are in doubt, use of intracameral antibiotics, and if a PCR happens, ensure the proper closure with sutures and check for the vitreous with the triamcinolone. So there is a study where the intracameral moxifloxacin, it is a very large study. That is by preventing the intracameral moxifloxacin, it prevents the endophthalmitis rate. So the post-operative precautions. So these days we tell our patients that the cataract surgery
What was the pearl here?
Yes, sir.
इससे पहले pearl क्या था?
Sir, these are the intraoperative. Intraoperative. So now the post-operative.
Yeah.
So we should use that is antibiotic steroid combinations, and a proper tapering should be advised, and it is very important to follow up these patients 2, 7 and 30 days protocol should be maintained, because the most commonly the end of picture we can pick up early if we keep the follow up at these days, 2, 7 and 30 days protocol. And intraoperatively, when the patient has more ganglion cataract, longer surgery, complicated surgeries, in those cases cycloplegics and oral steroids can be used. And that is drop-free approaches for cataract surgery. In India, I feel like that the post-operative, we have a medical college in the rural area, so we don't depend upon that is drop-free approaches for cataract surgery. We usually follow them at 2, 7 and 30 days to pick up at early. So, per 3, it is identify the red flag sign. What are the red flag signs that points towards the endophthalmitis? Unhappy patients, pain, poor recovery or sudden rapid diminution of vision, unexplained IOP rise is usually a very early indicator for to pick up the endophthalmitis at the earliest. Poor fundal glow, disproportionate AC reaction, pupillary fibrin membrane hypopyon in the anterior chamber. So it is very important to differentiate between the TAS and endophthalmitis. Pathogenesis is different, treatment is different, the prognosis is variable. So it is very important to differentiate between these two. So the TAS usually appears between the 12 to 24 hours, endophthalmitis, it takes 3 to 7 days. That is why we should see our patient on the second day and the 1 week of the surgery. And pain is mild discomfort in the TAS and moderate to severe in the endophthalmitis. Visual acuity, mild decrease in the TAS. And intraocular pressure, normal or maybe increased in the TAS. And early end of may be indicated by that is unexpected rise in the IOP after the cataract surgery and unexpected inflammation. Corneal edema, that is limbus to limbus, usually indicates the TAS. And fibrin and vitreous cells are usually absent in the case of TAS, and they are usually present in endophthalmitis. And hypopyon, if it is present, it is minimal or the absent and oftenly present in the endophthalmitis. So it is very important to get the B scan in these cases to differentiate between, whenever you are in doubt, do the B scan, and if there is no exudation in the vitreous cavity, it is pointing towards the TAS, and you have to see all the patients operated, especially on that day.
Dr. Rajvendra, I'll just interrupt you here.
Okay, sir.
Just coming, one day before coming here, I had operated upon 2 cases. Both
Yes,
had C3F8. And the first post-operative day, they had fibrin in AC. Now, B scan will not show any exudate. Now, was it a TAS or was it end-off? It was it was typically TAS, because I had never seen such reaction.
Yes,
The
sir.
third patient operated in the same OT with silicone oil did not have any reaction.
So the answer is
the
because,
cluster of-
Ajay, the answer is because in early stages of endophthalmitis, infective endophthalmitis
Yes, sir.
also, B scan may be anechoic. Because it takes time for,
Yes, sir.
that clumps to form so as to throw echo.
Yes, sir.
Otherwise, echo may not come also.
So
So it's more
yes,
often a
sir.
clinical diagnosis rather than an ultrasound
Yes, sir.
diagnosis.
So,
No, Ajay.
Yes, sir.
so role of ultrasonography and the diagnosis of acute postoperative endophthalmitis, then what next? So we have to differentiate. The time of presentation is very important indicator of about causing the organism. So if it is less than 4 days, we should suspect the gram-negative streptococci and Staph aureus. More than 4 weeks, that is the chronic delayed entry, that is delayed onset, fungi epidermidis, and acute, that is the Staph epidermidis, coagulase negative, and fungi rarely.
बहुत simplify कर दिया.
So it's very important that if a
So
patient
that is why I was telling ki this is important to see the patients, post-operative patients on the second day, 7 days and 30 days, so that we can pick up early these types of endophthalmitis according to the time of presentation. So if you want to add.
Yeah, yeah. No, it's, I think it's too simplified, but it's okay.
Yes.
We
See,
have
a
some pearls.
patient can present on day one with Pseudomonas.
Yes, sir.
I think that's very important to remember. So first 3 days are important, and if the patient is symptomatic, even if you've told them to come back on second day and they have problems, they should report as soon as possible.
Yes, sir. And how do we clinically identify a highly virulent organism causing the acute post-operative endophthalmitis? Onset within 2 days of surgery and initial visual acuity, they can come with the rapid deterioration, loss of red reflex. Corneal infiltrate is a high indicator for the Pseudomonas, then we should suspect. Then it's pupillary involvement and cataract wound complications, especially the wound leak. So the presence of hypopyon in isolation does not rule out in and out of the highly virulent organisms. So virulent and non-virulent. If we are suspecting the virulent, it means the management is to be aggressive, prolonged course, multiple interventions, poor visual prognosis should be explained to the patient and relatives. So in
You
these,
will have to wrap up, I think.
Okay,
because
sir.
You will have to wrap up.
Okay, sir.
You want to show some video, then it's,
No, sir, no, sir, there is no video. So the counseling of the patient is important. I will go through the main points only. Intravitreal antibiotics. So earlier
I
the
think
batter,
these
the
are
moment
okay,
it
these are
worsened.
okay. I don't think so these
Okay,
are
sir.
required. If you have some video, I think that will add some value to this thing.
So then pearls for vitrectomy. Sir, whenever we are suspecting the early vitrectomy has a role, if the vision is less than by 6 by 60, so better to use 6 mm cannula as the choroid is thick and inflamed, clear fibrin from the
If the
AC
vision is
first.
worse than 6 by 60.
Yes, sir, we can give the
Do a vitrectomy.
intravitreal antibiotics first, and if the vision is deteriorating in spite of the intravitreal injection, then we can take these patients for early vitrectomy. If the patient is improving, then we can wait for the surgery. And then send a dry vitreous tab for gram stain and QH stain and culture sensitivity. Intravitreal antibiotics with DEXA at end of the surgery. In severe endophthalmitis and PVD induction, you can put the silicone oil and avoid oral steroids in diabetics.
I differ here. I induce PVD even in vitrectomy for endophthalmitis, and that really cleans up the thing. Otherwise, it looks very dirty even if you do vitrectomy.
Yeah, yeah.
Yes.
So
Anyway,
what is the
the
final
take
take home
home
is?
Yeah.
Intravitreal drugs are
So
first aid.
intravitreal drugs are the first aid. Early intervention can save the eye, and always inject before sending the patient to higher center. Except anyone can have an endophthalmitis, we have to act early.
All these
And,
4 points are very well taken.
They're
All
very-
these 4 points
Yeah,
are
and
very well
especially
taken.
for the anterior segment surgeons, what I'm surprised is that they all can give very good intravitreal Avastins, but they don't give intravitreal antibiotics.
Yes,
So please, if you can give Avastin, you can give antibiotic too.
No, this point is very well taken because always inject before. We have seen, I personally have
Yes,
seen
sir.
whensoever my friend has given, by the time he comes to me, I get the credit, but kaam to usne kiya tha, because he gives the injection, by the time he comes, he's improved already.
yes, sir.
That's all 4 points
Yeah,
are very
that
good.
is the most important point, take home, that intravitreal injection must be given by everybody.
Yes, sir. Thank you, sir.
Chal, thank you, Rajvinder, for these good points, and I think next time you should have some videos also.
So I would like to ask your experience regarding when to take up the patient for vitrectomy.
You see, we can, Neha, go on and on, but there are 5 talks remaining. We will, if time permits. Because when to go for vitrectomy, answer is one is very severe end-off, which she also said. The second is non-responsive to intravitreal injection, first intravitreal injection. So today we have very low threshold. You see, we don't keep giving injection. So if first end-off, if first injection has not worked, or if the culture sensitivity report is available, then you can re-inject. Otherwise, go ahead for
Go
vitrectomy.
ahead with vitrectomy.
Early vitrectomy will give better results rather than waiting or deferring vitrectomy.
Yes.
So let's hear now a very important talk that is setting up a practice.
She's
No,
not there.
He is not there, Aditi is speaking.
Interpreting OCT. Acha, this we should have done before only. Yes, Aditi.
At the outset, I'd like to thank AIS for this opportunity. So it's a very basic talk to look at some of the most common things one sees in the OPD. So it's not just for the retina people, because we day in and day out see OCTs. It's also for anterior segment surgeons, because
Dr.
some of
Nitin
these
Nanda is not there? Okay.
can help you prognosticate better. So OCT was first done in 91, and over the years it has evolved, of course, to STOCT, SSOCT, and now Octa. So I'm skipping that part. Oh, to interpret an OCT, one must know what a normal OCT looks like, and it looks like this. And we have a nomenclature that gives us these 18 points of all the layers that are on the OCT. And one must know this to be able to interpret at which layer what disease is existing. And it's always better to understand and read every OCT layer-wise so that one does not miss things. So I'll go similarly and also with a mix of few common conditions that are seen. Typically in the vitreous, you may see some, early bleeds. This is obviously a frank bleed. There is a subhyaloid hemorrhage which can be seen right there. But sometimes even posterior vitreous cells, which are very subtle, or a very, very mild bleed can be seen on an OCT at the vitreous interface. Moving on to vitreomacular disease interface disorders, there is the big bright yellow arrow that shows a very fine ERM, and clinically you may be able to pick it with the particular sheen. The other OCT is of course of again ERM with distorted retinal layers. So that's an epiretinal membrane. Again, in vitreomacular traction disorders, we have vitreomacular adhesion on top, and also vitreomacular traction, where it also pulls the retinal layers, which can either be focal or broad. And that's based on whether it is less than 1500 micron or more than 500 micron. We also have macular hole and various stages of it, right from the traction to an impending hole with partly the operculum attached to a full thickness macular hole. Very commonly seen in our OPD. We also have a pseudo hole wherein you can see that the ERM is causing a tangential traction and there is a verticalization of fovea. So that's a pseudo hole. And then you may have lamellar hole, where typically you may have split in the retinal layers. There can be loss of tissue as well. Very commonly seen as diabetic macular edema. It becomes important to understand which is center involving. Some of the ones shown here are center involving. Non-center involving are typically not treated with an anti-VEGF, and central involving is treated with an anti-VEGF. Here you have different types of it, though we most commonly encounter a mixed variety of all this. We have spongiform, cystoid, you can see the cystoid spaces, serous, and tractional edema. And we may also see a taut posterior hyaloid in some of these diabetic retinopathies. Here I would like to stress on the biomarkers beyond the scope of this talk, but it becomes important because this can affect vision. Drill is disorganization of inner retinal layers. You can see on one side, you can make out the retinal layers very clearly, whereas on this side, you cannot really make that out very clearly. So that is indicative of ischemia and also poorer outcomes. Others being hyperreflective foci, which differs from our hard exudates as they are smaller, they don't have backshadowing, and it shows chronic inflammation and long-term edema. And another important factor is to always look at the outer retinal layers. If their integrity is not maintained, your visual outcomes long-term are not going to be great. Moving on quickly, the first OCT may look normal at the first glance, but you can see a slight hyperreflectivity right there. That is early stages of a PFT or a MACTEL, macular telangiectasia, and that of course is the ILM drape sign, typically said to be a degenerator of Mueller cells. So sometimes clinically it becomes difficult to pick up these, especially in today's era where you are planning premium lenses. Clinically are not able to pick this up, sometimes may have visual impact later. Moving on, any guesses? One of the most common things again you may see. A subtle clue here.
Arterial.
Yes, that's arterial occlusion, and that's how an acute one looks with inner retinal hyperreflectivity and a darkened outer retina. And sometimes you may get a patient who's once had an arterial occlusion comes back with a complete thinning of inner retinal layers. That's how it looks on a chronic stage. Similar thing if it happens to one branch, that's a BRVO. Same thing, any occlusion. Sorry, BRAO, I'm sorry about that. BRAO, you have the same thing, ischemia, therefore whitening of the inner layers, darkening of the outer retina, and you see a normal retina on the other side. Look very carefully, you can see two white patches there. These patients may come to you saying, of a central or paracentral scotoma. And this is a very subtle thing. It's a middle layer ischemia that leads to something called PAM, parafoveal acute middle maculopathy. Clinically, they may look normal, but you can pick this up on an OCT, and you can obviously tell the patient that there has been an ischemic itself. So these are the things that we saw occlusion at various levels. Cottonville spot is, of course, occlusion or a nerve fiber layer infarct. So I've just put it there. Moving on, vein occlusions. Vein occlusion here shows a massive edema, and clinically, of course, you see substantial level of hemorrhages all around. Same thing when it happens in a branch. You have a branch retinal vein occlusion, and you see edema involving only that section where you can see cystoid spaces, a small sensory detachment right there. Moving on, another common disease is age-related macular degeneration. The dry variant typically has drusen or geographic atrophy. In drusen, at the layer of RPE, you can see these tiny bumps. They are, and in geographic atrophy, you can see the entire central subfoveal area where the outer retina and the RPE, the entire thing is atrophied. Neovascular AMD, of course, can be another topic of discussion. There are various types of it, but typically you see a membrane. Here you see one above the RP with a lot of intraretinal fluid, clearly requiring treatment with an anti-VEGF. Another common thing that you can come across is young patients coming with this detachment, and people not able to sometimes differentiate what it is, but it's very common to have CSCR, and it is self-resolving. Typically you see a PED with a serous detachment right there. This is also commonly seen these days. You have something like a notched PED, you can see a notch there, or a thumb-like PED with subretinal fluid, and a double layer sign. You can see a Brooks layer separately and the RP lifting up with some fluid above it. Typically PCV, of course, there's a lot of variants of the entire pachychoroid spectrum. Here, look very carefully, it looks normal, but you can see a slight split there, right above the RPE, that denotes a photic retinopathy. So sometimes it's important. Some people may have blurred vision because of this. Another common thing is ocular trauma. Of course, it has a very frank, ghastly picture sometimes with bleed and choroidal rupture. And this helps us show the patient also why the vision is less. And subsequently with these ruptures, you may have CNVMs later and all of that. So helps in documentation, educating the patient, and also warning them of what can go wrong in the future. Look at this very carefully. You can see that bright RP band, and above that you can see a small layer of photoreceptors. Now that has to continue on either side, but it stops right there on either side. So this is a case of retinitis pigmentosa where there is a parafoveal loss of photoreceptor layers. So sometimes what happens, I've seen a lot of cataract patients, clinically you may not be able to see those bunny spicules, attenuated arterioles, but scan can show you this, and you can certainly explain things to the patient, prognosticate better, and guide better.
Dr. Diti, can you please wrap it up?
Yes. So to summarize, the OCT is an important, extremely important tool for all subspecialties, I feel, because it's a simple tool, and it's very graphic, and it shows you all the diseases very clearly in the layers. Thank you.
Thank you, Aditi. It's a very tough task, 7 minutes, an entire OCT book, virtually you have summarized, but I think you gave a lot of very, very good examples. But you see, to suffice, I would like to say, whenever you are interpreting OCT, don't behave like super consultants and say edema plus and give injection. That's what, where most of us falter. So you should have those 4 lines always written up. Like, a lot of people interpret X-ray and correlate clinically. So we see a lot of such nonsensical, stupid statements. But like you rightly started, start from vitreous, interface, inner retina, outer retina.
Yes.
Then you will never falter what you are dealing with. So message is that don't write edema plus an injection. That is what is becoming, spoiling everybody, in fact. So if you follow what you have said, start from vitreous, interface, inner retina, outer retina, you will always benefit. No?
Yes, certainly.
So I think with this, We have a lot of things to be discussed, but because of shortage of time,
I am
think-
around.
yeah. So Ajay Arora will tell us now about CSR, and he has a huge follow-up of 10 years of his own data on micropulse laser. Yes, Ajay. So
Thank you. At the outset,
actually
I
we have
must
already
thank,
finished on time, but
I must thank All
yeah,
India Ophthalmic
yeah.
Society for giving me this opportunity. Thank you, Dr. Lalit, and all the panelists. So I'll be talking on how to manage CSR, my experience of over 10 years. These are the financial disclosures, and I think all of you know that acute CSR, we must observe patiently for about 6 to 8 weeks. We don't want to intervene. We definitely want to make sure that steroids are removed from the usage by the patient, reduce stress, and stop smoking. When you have chronic CSR, which could be either a non-resolving CSR, a recurrent CSR, or a chronic CSR or an inactive CSR. Now, for these cases, a lot of systemic medications have been tried. Thermal laser has been given for extra foveal leaks. PDT has been done, but the dye is not available, and the micropulse laser. So there are numerous systemic medications which have been tried. I don't use most of them. The only thing which we may use is carbonic anhydrase inhibitors, antioxidants, and sometimes, very rarely, epinephrine. I am not fond of using epinephrine at all, except when there is a inferior detachment in case of CSR, when may use epinephrine. My go-to methodology is micropulse laser. So I don't want to use all these medications because it can cause a lot of systemic problems, the medication itself. So for me, PDT is out because dye is not available, and of course these systemic things is off, and for me the go-to method is a micropulse laser. So what is the treatment protocol for the subthreshold micropulse laser? I don't use it in acute CSR except patients who are symptomatic and do not wish to wait for 3 months. There we have used in some cases. We used only in cases of chronic CSR. A micropulse laser is not same as a subthreshold laser. This part you must remember, because micropulse laser, the pulses are electronically divided to make it into micropulse, and this is what it is. If it is a 5% duty cycle, that means if, for the 2 millisecond laser, it's divided into the gap is about 1900 microseconds, which is no activity, and about 100 microseconds where activity is there. So that is what micropulse laser is all about. And people invariably said, what is micropulse laser doing? I can't see anything. So there was a beautiful experiment done in Japan on immunohistochemistry, where they showed that micropulse laser, you will see here the micropulse laser getting activated, and you can see that ring being forming. This is for the heat shock protein. Now we have internationally we formed a group which is a subthreshold laser group, which has said that the parameters are that you do a test spot in a micropulse mode and then bring it down to 50%. There also you have to titrate it. Like for CSR, I follow a percentage between 35 to 45%. And these are the various methods of titrating. What I do is that I do a test burn in the micropulse mode, and then I reduce and this is done nasal to the disc, and then we reduce the burn, the percentage, and bring it down to about 35 to 40% of the micropulse laser burn. So this is a series of about 42 eyes, which included 7 females. 29 were unilateral. There were 3 males which were bilateral. I will just show you the examples, not go into many of these details, but 90% of them responded by 3 months, and rest of the cases did need a second treatment for them to respond, and most of the cases have responded. So these are some of the acute cases where we have done and the patient have responded. This was a series of 15 eyes we did in acute CSCR, and all of them responded with micropulse laser. That these were just a small study that was done. I do not recommend micropulse micropulse laser in acute CSCR. So this is various cases of chronic CSR I'll be showing you. So this was a patient who was a laparoscopic surgeon who had been treated with apneiron, had been treated with thermal laser, had been treated with TTT, and he came to me with CSCR. He was 6'6", but had recurrent episodes with metamorphopsia. So this is, I've been following up for last almost now 5 years. He has had multiple episodes and he is doing well with subthreshold micropulse laser. And he asked me, why was I not referred to you earlier when a micropulse laser? So this is what I'm saying. You must give them the option and find out who is doing micropulse laser, because patient may start asking you this question. This is another patient of chronic CSR treated with micropulse laser, did well. And this was a dentist. For 5 years he had had a chronic CSR. His complaint was basically against was metamorphopsia. And we did an octave with this patient, and we found that in the right eye he had a macular neovascularization, which was like IPCV. So whenever we do a patient with micropulse laser, we do an octave before to rule out a choroidal neovascular membrane, treat it with an intravitreal injection of aflibercept in these cases, and only then, whenever we are sure that there is no membrane present or that is quiescent, then we go ahead and do micropulse laser in this patient. So this patient was treated for both eyes micropulse laser. I'll give you the example. So the right eye was treated with ILIA, and 1 month post ILIA he received micropulse laser treatment. So in the left eye, after treatment, within a week, actually the central thickness may increase. Patient did not, so we follow up on a sequential manner. Patient was not symptomatic, but I found that the central thickness had increased, but over a period of a month, the central thickness was brought down and it was 6'6". This is an ophthalmologist resident. During his residency, he came to me repeatedly during 3 years and was treated with micropulse laser, and after his residency is over, his stress has gone and he is doing well. So this is about micropulse laser. We have had an opportunity of treating a patient with CSCR in pregnancy. So one way was to wait, but the patient did not wish to wait. So we went ahead and treated with micropulse laser, and the patient responded well. This is the octa and the same patient. Patient did well. So in conclusion, workup of a patient for subthreshold micropulse laser, we do an autofluorescence, we do a colored fundus photography. You can see the tracks of CSCR in these cases, and this represents that it was an old CSR and we do an OCT and then see if there's a neurosensory detachment. We do a test burn, and after doing the test burn, we go ahead and treat the macular area. So in conclusion, take-home messages: subthreshold micropulse laser works in CSCR consistently. Chronic CSR may need this may need to be repeated. You must titrate in every case. There is no standard power which is used in cases. And I titrate after doing a test burn. I bring it down to about 35 to 45%. And apneiron can be used in certain cases, but a micropulse laser, it does give you a good results. Thank you very much.
Thank you, Ajay, for elaborating usage of micropulse, I think which is underused, as I would say. Do we have Isha Acharya?
Dr. Arora, can you use this machine for some other purposes also?
Or
Yeah. So micropulse laser I use for routine laser. I use micropulse laser in venous occlusions, micropulse laser in diabetic retinopathy. In all these cases we have done, and I have recently used in cases where a patient of AMD is not responding to anti-VEGF. This is a recent thing that you treat them with micropulse laser and they start responding back to an anti-VEGF.
And you have a separate green laser separately and this separately. You have two machines?
No, the same machine, you have a micropulse mode. Basically, you have a scanning laser, so you should have the multi-spot this thing, because you multi-spot spots are given. The spot distance, there is 0 spot distance, so that's how it works.
Chal, I think we'll hear Veer Singh. I think this talk is beyond anti-VEGF. Are you going to talk about Vabysmo or?
Sir?
Beyond anti-VEGF, is it on Vabysmo?
No, sir, it's on. It's a Bayer sponsored talk.
Okay. Beyond simple inhibition, multifaceted molecular characterization of anti-VEGF. बहुत लंबा topic है.
So mine is a Bayer-sponsored talk. It's about beyond simple animation, multifaceted
5
molecular
minutes show to him here.
characteristics on anti-VEGF. So I'll try to wrap it up. So VEGF signaling pathway is basically pathological. It results in angiogenesis. We know there are VEGF1, VEGF2 receptors, and VEGF-A, PLGF, VEGF-B. These are the molecules which activate them and cause inflammation, neovascularization, retinal vascular leakage. Now, VEGF, anti-VEGF agents are tested mainly in like these 5 factors: binding affinity, half-life, potency, clinical targets, and molar dose. So binding affinity is basically determined by something called KD, or dissociation equilibrium constant. The lower that is, the higher the affinity is, and that's what we want. So aflibercept here has the lowest compared to, which is then comes brolucizumab, and ranibizumab, faricimab are similar. Coming to IC, or this is the potency. Again, the lower that is, the higher the potency the molecule will have. Here again, aflibercept stands out as compared to the rest of the molecules. Now, half-life again, if we see, it's basically how long a drug stays in your eye, and it's quite comparable to the others, but again, it is much more significant as compared to the other molecules. Target molecule. Now here we have single target molecules which are brolucizumab and ranibizumab. A dual target is faricimab, which is VEGF and Ang2, and multifaceted. That's what we meant, like four targets: VEGF, PLGF, VEGF-B, and galactine. Now, aflibercept targets VEGF, which is the master regulator, as a result, but along with that, it additionally targets the PLGF, and that's how the extended the effect that we have with the aflibercept. We know that there is a great fold increase in DME of these VEGF and PLGF levels, which comes down to a significant level with just one shot. But again here, as long as PLGF is not targeted, it again upregulates the VEGF. So hence it's important to target PLGF as well. Now, could targeting additional pathways beyond VEGF result in improved efficacy or outcomes? So there are all these different molecules that you can target. Aflibercept targets these 4, and there have been studies targeting the platelet-derived growth factors with eye drops and intravitreal injections, and they've shown no extra benefit. So coming to the newest, does Ang2 have an extra edge? This is a document from the FDA open source website. Here it says that the faricimab is a humanized bispecific IgG monoclonal antibody directed against VEGF and Ang2, and the VEGF antigen binding fragment is identical to ranibizumab, and the contribution of Ang2 inhibition to the treatment effect and clinical spots of neovascular AMD in DME is yet to be established. So is the Ang2 tie to pathway, which is the tyrosine kinase pathway, relevant target for treatment in exudative retinal disease? During angiogenesis, the Ang2 is upregulated and competitively binds Tie2. Now, many studies have shown that Ang2, there is a response when we target Ang2, but there are some studies which show that basically it causes stabilization of the vessels by blocking the Ang2 receptor. Now, some studies show that in high VEGF states, the Ang2 has an antagonistic effect, which may promote, in fact, destabilization. And in lower VEGF states, it may have very limited or even no role because already the VEGF load is low. Now, aflibercept here is the most potent binder of VEGF compared to others because of the PLGF effect. Bayer and Regeneron have themselves done their trials on Ang2 antagonist, which is nesvacumab. Now, the affinity of nesvacumab, for a reference, the tyrosine kinase affinity for Ang2 is 3000, and nesvacumab has a stronger affinity than faricimab, but yet they did not see any additional benefit when they, as compared to aflibercept monotherapy when they used them, Ruby and Onyx trials, and hence they were discontinued. Now the studies.
You see, this trial was a superiority trial. This trial, what you are quoting, Ruby and Onyx, they are superiority trials, not in non-inferiority trials. Yeah. So there's a difference between all the trials, whatever we are, quoted, misquoted, are non-inferiority trials. And this Ruby and Onyx was superior. They wanted that maybe this is superior. उन दोनों बहुत फर्क आ जाता है.
So ultimate outcome was it was non-inferior then to the monotherapy.
Yeah.
So basically, the trials that have supported faricimab, more or less at the end point, 56 week or 46 week, the letter gain was almost similar. Now, faricimab phase 2 trials, ranibizumab and faricimab achieved similar levels of plasma Ang2 with just one injection. A single dose of ranibizumab 0.5 mg reduced the plasma, which is the lower level of quantification, to with just a single dose. So data suggests that anti-VEGF monotherapy neutralizes Ang2 levels and to levels comparable to that directly targeting Ang2, supporting that known biological activity Ang2 basically is activity is downregulated by decreasing VEGF levels itself only. So aflibercept as compared to brolucizumab and ranibizumab, it prevents the anti-VEGF basically driven Ang2 production much better than the brolucizumab and ranibizumab. This effect is greater and persists longer with aflibercept versus brolucizumab and ranibizumab. So the results of this study basically support that hypothesis that Ang2
what are you
may
trying to
be
say?
expressed.
Aflibercept shows suppression of Ang2.
So there are studies which say that the VEGF-A, when you control that, so Ang2 is produced secondarily to the
meaning
elevated
that
VEGF-A
if you
levels.
suppress VEGF, that also gets
So that
suppressed.
automatically
Yeah.
goes down.
But it's not an independent.
It's not a direct Ang2 suppressor. So that's what they're trying to say, that may not be required. So the activator.
So therefore, the effect what you are saying of faricimab is by and large equivalent to that of ranibizumab.
I'm
I'm
coming to that. Yeah. So the activity of faricimab, what we have seen is that it has a prolonged effect. So hence, it is lesser number of injections as compared to ranibizumab. Now here, when you see that the binding affinity, the estimated half-life, everything is similar to ranibizumab. The only thing that differs here is the equivalent molar dose. So as a result, since there is clinical data to suggest that Ang2 may not have that extra edge, it could possibly be that the higher molar dose of ranibizumab, the Fab arm, may be responsible for the faricimab effect. So with aflibercept 2 mg already targeting key ligands of master regulators, the VEGF pathway, there may be limited potential for improvement in functional outcomes for patients. Summarizing all of them, aflibercept in all these criteria is superior to all the other molecules. The only where it stays back is the molar dose, and which is more in faricimab, which is more in brolucizumab, which probably is what they're trying to say is that which probably is the reason why we get that faricimab effect. And
that effect is primarily duration. That effect is duration.
Exactly. And that again has, with further trials which I have not mentioned here, so I'm going to conclude with that. With further trials, we've seen that AIOCMTC4 HD is kind of equivalent to the faricimab effect as well. So I think I'll leave that to the summary slide so for everybody to see. Thank you.
I hope there are no Roche people here, otherwise they'll kill you here only. because if you say there's no Ang2 at all, वो तो सारा studies ही Ang2 पे होता है.
Sir, nobody can say there is or there isn't. There are studies supporting it and there are studies opposing it.
So हम कहाँ जाएं?
So
where do we go?
अपनी literature search करके experience से.
Sponsored talk means that you take a neutral stand.
No, so basically the thing is that I believe in this molecule and I've used it, and I've used a lot of faricimab as well. And being, say, an unbiased...
So let me ask you a direct question. You prefer faricimab or you prefer aflibercept?
I prefer Eylea in general, but wherever Eylea fails, I prefer Pegenex. So that's what I'm trying to say.
So faricimab has no role according to you?
So, I mean...
Why were you disillusioned by faricimab? What did you see that you got disillusioned by it?
So I've used it in cases, basically I've not used it in treatment naive cases, let me be honest about that. I've used it in only treatment resistant cases.
Which patient are you talking of? Faricimab?
Faricimab. CNVM patients and a lot of polyp cases. And I've not really seen, I mean, compared to either one of them. So because of the patient support program, I am a
Honestly,
big
Veer Singh,
user.
before I think you make any statement, you should have a comparative data in treatment naive. Otherwise, I don't think so. You can make any statement. You should not.
So basically, this comparative data is the basis of what the theoretical part is.
What
And
I
my
would,
experience is
what I would
obviously a
advise
separate
is,
thing.
what I would advise is, you have a lot of patients in your hospital. You do a comparative real-world scenario.
Yeah, of
In
course.
real-world scenario between this Farsimab and this, then come out.
Of course, sir. When I have that amount of
Next
data, I
time
will
we'll hear
definitely do
that.
it.
Next time we'll
When I
hear
have
that.
that amount of data, of course, I will do that.
And in treatment naive cases.
Yeah.
In treatment naive
Any
cases,
other
sir,
comment
maybe
by
a
anybody or-
far-fetched idea.
A chronic case may not respond to anything.
So, that may be a far-fetched idea because of the costing. I don't think that's realistically a possibility to do treatment naive cases with faricimab.
But you see, all these studies of Faricimab or even Pagenex, you see, what I tell all these people is, they always compare with aflibercept only. All of them have compared non-inferiority with aflibercept. Indirect even saying that aflibercept my baap hai, uske saath hi hum compare kar rahe hain. That's what you are saying.
So Pagenex is also a very good molecule. In my practice, I think at the moment, faricimab doesn't have a space.
Does not have a space.
Does not have any place.
Ajay, both the Ajays.
So see, standard of care,
Answer,
right?
you agree or not? Yes or no, or you want to modify?
No, I would, since it's a new kid on the block, I would definitely like to try, and I've tried in 2 cases. And I would like to try it in few more cases
How
before
was
I
it
say
result
that
in
I
2
don't
cases?
believe in it.
How was it result in 2 cases?
I tried in a PCV case, it did not work.
So 50% it worked.
So it did not work in PCV.
Ajay, Arora?
In diabetic case, the first injection did not work. So I was disillusioned, but the second injection was patient support free injection. I gave it. And after,
Because it was free.
After, yes. And after the second injection, the effect started coming gradually. And this patient was responding only and only to Ozurdex, to no other molecule. So now when the effect has come after a few weeks of second injection, I've decided to go ahead with all 5. So I've just injected third few weeks back.
Ajay Arora?
So faricimab does work, but it doesn't have a wow effect which was promised earlier. It doesn't have that wow effect. So I have used in a few cases. It does work, but it is not as effective. So my go-to molecule still is Eylea. I do use Pagenex where nothing else is working. Pagenex does give a wow effect. The Pagenex, only thing we are concerned about is whether it will cause an intraocular inflammation. So I just pray when I have injected Pagenex in the patients.
So my disclaimer is I have not used in any, I've only used in AMD. So more specifically PCV.
So next time Veer Singh will hear from you your real world.
Sure, sir.
Okay, I think any comment from the house? We'll otherwise wind up the session. So thank you all the speakers and for making this
We
session.
will have a photograph of speakers. So
Group photograph.
Dr. Veer Singh, come. Aditi, come.
Aditi, everybody should be here.
Come.